this patient is male, 54 years old. Clinical presentation is exertional chest pain for 3 months. No risk factors. Clinical diagnosis was stable angina pectoris. EGFR and BNP was normal. Electrocardiogram showed T waves inversion in late V2 to V6. Ultrasound showed ejection fraction was 66%. 20 days ago, we performed the angio for this patient. This distal left main was mild stenosis. Proximal and distal circumflex was about 90% stenosis. OM1 was severe stenosis. Proximal LAD was about 80% stenosis. Cranial view, we can find middle LAD was CTO lesion. Entry point is not very clear. Middle right coronary artery was a mild stenosis. We can find the lateral branch to LAD. And we can see calcification in LAD.
Originally, I think this is a complex bifurcation located at the distal part of the distal left main. But when we focus on the EKG change for the patient, we think LAD was not very important compared with circumflex. So I think maybe provisional T for this left main with circumflex with the main vessel, I think it's a very good option. This is today's angio, previous one. With spider view, we can see the distal left main bifurcation lesion with severe stenosis located at the proximal circumflex and ON. The middle LAD was totally occluded. So next, we use 7 French guiding catheter with 375 EBU for left coronary artery and 7 French cell 1.0 for right coronary artery. We also can see from the AP cranial there is a good collateral from the distal RCA to the middle LAD. With we can see from this angle, the CTO segment was very short, less than maybe 10 or 20 millimeter. So we also can find the severe calcification located at the proximal to the middle LAD. And we use AP cranial with a double angle. We can see the CTO side very clearly here. So next, we change to the aerial cranial. We can see from here. We also can see the entry point clearly from the aerial cranial. So we use so next we use Field XT while with our first choice with microcatheter support. This is XT while to negotiate the entry point of the LAD with microcatheter fine cross support here. We can see from the retrograde angle, the XT goes through the CTO segment successfully within 2 millimeters. So next, we also can push the microcatheter distally when exchanged to the workhorse wire with a 2 oblong pre-dilate the CTO segment. After that, so next, we check with IVUS. Just because we don't know the exactly time of the previous myocardial infarction of anterior wall for the patient, so we cannot see the LAD distal diameter clearly from the angle. So we check the IVUS after we with 2 oblong predilation of the CTO segment.
The first run, we check IVUS from the distal LAD to left main. We can see this point, the distal LAD is very distal. And here, the vessel is normal. And the vessel diameter is just 2.0 millimeter. Then go and pull back. Here near the septal, we can see this point is the distal landing rule. And here, the vessel diameter is about 2.6 millimeter. Then go and pull back here. Near the septal, we can see medial dissection. And here, this is the bifurcation. We can see the hematoma. Then go and pull back here. This is a middle LAD. And here, the vessel diameter, it is is about 3.0 millimeter. Then go and pull back. Here we can see the guide wire is a diagonal guide wire, and here this is the bifurcation.
Okay.
And here we can see the calcification, and the calcification angle is about 270 degrees. Then go and pull back. This is a proximal LAD, and the proximal LAD, the vessel diameter is about 4.3 millimeter. Then go and pull back. This is a proximal LAD, and then here we can see the circumflex virtual LAD. And here this is the ostium LAD. The ostium LAD area is about 7.8 millimeter square, and the plaque burden is just 53%. Then go and pull back. This is the distal left main. The distal left main area is about more than 13 millimeter square, and the plaque burden is not more than 50%. Then go and pull back. This is the body left main. The body left main diameter is more than 6 millimeter. Then go and pull back. This is the ostium left main. We make sure from the distal landing rule to the LAD and the diagonal bifurcation, the netness is 28 millimeter. From the LAD and the diagonal bifurcation to ostium LAD, the ness is 30. And the left main ness is about 15 millimeter. Okay, this is the LAD IVUS.
Okay.
Yeah, the second round we check IVUS from the diagonal to left main. And here we can see the diagonal, the distal diagonal is normal, and the vessel diameter is about 3.0 millimeter. Then go and pull back. This is the proximal diagonal. The proximal diagonal, we can see the area is about 2 millimeter square, and the plaque burden is more than 77%. Then go and pull back. This is the proximal LAD. Then go on. Here we can see this is the LAD and the circumflex bifurcation. We measure from the diagonal landing rule to ostium LAD and ostium LAD. The netness is about 33 millimeter. Okay, this is the baseline everything needed. Thank you.
So before standing osteo LAD to the middle part of the osteo diagonal, after pre-dilate with the distal circumflex, I want to check the IVUS from the distal part of circumflex to the left main. So before standing LAD, I just want to standing circumflex distal lesion first. So we put stand from the osteo LAD to the diagonal proximal part. Wait a moment. We use a traditional T tactic test. Okay. So this is a domestic jugular stand with nominal pressure is 6. From the angel, we can see the balloon expansion was very good. After that, we pull back the. Okay. So we will check the angle. We will find the flow of the anterior wall. After post-dilation with the 3O balloon from the distal part of stand and the proximal part, and the highest pressure was 18. Okay. After that, we check the angle. Okay.
Good. Looks much better.
So we will rewind to the LAD again from the distal part of the diagonal. This is the 2 balloon in LAD and the 3O balloon in diagonal graph with a low pressure, 6. Maintain for at least 30 seconds. That's because we want to resolve the dissection at the middle part of the LAD and the hematoma. We can, yes, the distal part of the lesion, maybe there is a hematoma, but proximally, maybe some dissection. DCP for this, I think is the best choice, just because after we opening the CTO LAD lesion, we can see the mismatch between the proximal part of the proximal and the distal part of LAD. That's because the CTO duration was, we don't know clearly, maybe longer. So if we're standing now, maybe after half a year or 1 year, there is the distal part of AD become bigger and bigger. So we will find that the stent was on the size. So I don't want to stating now. Just DCB is a good choice. No, wait a moment. Just because it's a 2 balloon, feel a little resistance here. There is some totals of. I just want to perform in kissing with a 3O in
0 in diagonal,
Yeah,
2
0
in
in
LED.
12, 14.
14.
Okay, done. Yes. After that, we perform kissing with a low pressure in LED and high pressure in, or moderate pressure in diagonal. It's 3O kissing, 2O balloon. Okay, got. I will check the angle after kissing. So give me 2O balloon to predilate distally. 4.
Four.
4. Enough. Just because this the part of LED, the diameter was about 4 or 2. So we think this is a 2O balloon.
So clearly there is a competing blood flow distal to the balloon.
Yeah,
So I think you can down
done.
and put balloon more distal, little bit distal. Distal. Okay, right here.
3. If it is possible, I will perform kissing, final kissing. Just because if we only use a DCB, we will find the stent criner shift to the mass. So I think after ballooning, this the middle part of the LED, final kissing can resolve the stent criner. 3O NC balloon. Yes, this is a 3O NC balloon. We will perform the final kissing and we perform the pot. Okay, kissing.
5.
Good.
Okay,
I think
done.
position is very good.
Yes, the patient was is very, very stable during the whole procedure. After inserting nitro, we check the IVUS for the LED again. No, push a little forward. Yes.
Left man looks good. Good, I think.
Yeah.
So after IVUS, one more injection of nitro and to check the angiography again. If the flowing ID looks good, so I think during the remaining time, if you need to move to synflex and obtuse marginal.
Nitro again.
So long as diagonal is fully standing, I think it will be very safe for the patient.
Yes.
Good.
Okay. So after that, we will check the IVUS for the circumflex. So we will standing distally
Yeah, I
and wire
agree.
in the,
I
yes.
agree. So I think I probably need a 3 by 33 stand.
33
Maybe
stand.
by up to IVUS findings.
Yes. Flush. We will check the IVUS for the circumflex for the first time. And we will find the distal part of circumflex with severe stenosis after we predilate with 2O balloon.
There are some calcification.
Yeah, this is the O.
I
This is
think
OM.
this is the proximal side branch.
Yeah. Previous one.
The
Angel.
vessel
Previous
is more
angel.
than 3.5.
Okay, the very proximal lesion in synflex.
Yeah.
Huge vessel. 4. 1, 2, 3, 4. 4.
It's a
LED.
LED.
This left man looks good. It's good. Okay, so now Xiaoban, you need to measure the distal lesion length insert.
Previous angel. Show it to me. Yes.
Thickness is 30.
30.
30. So it means 3 by 33.
Okay, 3O 33.
So what's this then? Oh, expedition.
Expedition. Previously O and C below. So the proximal part of the stand, the reference diameter, Chopin 4035.
I think it should be to be full.
For okay, prepare for all NC balloon for me. This is a 3.0 by 33.
No, I think for. So, but if it was your question about the NC balloon, because this is 3.0 stand.
Yes,
So you want to use a 4.0 NC balloon to
pre
post
the
that?
proxy part of it there.
Okay.
Just because okay, the diameter was mismatched between the
Right.
proximal and distal. Okay, Sydney test.
So 3.0 NC balloon. You have I remember you have one 3.0 NC balloon on the table.
Yes, we have one.
So
So
after that, I think a pod balloon.
distal. Yes, pot balloon.
Oh, short pod balloon.
Okay.
Mm.
Pot balloon. Prepare it
Okay.
for me. Okay, test.
4.06. I think it's a good position.
Okay, got
Very good position.
8,
8,
10,
10,
12.
So this is a very challenging case. Diffuse lesion, calcified, also multiple bifurcation lesion.
Yes, multiple bifurcation lesion. Yes. 3.0 NC balloon. So we use a pot balloon to perform post-dilation. Pot balloon is a very, very good, very special balloon. Not only for pot, just also performed for post-dilation with a very short shoulder. From this angle, we can find that the shoulder of the balloon was shorter compared with a conventional NC balloon.
This is a 4.
No, 3.0,
Oh, 3.0.
3.0,
Okay.
12 pot balloon. Compared with conventional NC balloon, we can see the short of the balloon was very short.
14,
14, 16, 18, 20. Yes, get down. Let's go up.
20,
20. Okay. Down. Up.
16,
18, 20. Okay, down. From previous angle, we can find some calcified lesion located at the stand segment. So when we perform nominal pressure of the stand, we can see the stand was not full expansion from the angle. So we use pot balloon to perform final post dilation with very high pressure balloon, about 20 atmosphere. Okay, go up. Okay, 20. Okay, down. Prepare 4.0 pot balloon for me to post dilation of the proxy part of the stand. Yes, go up. Okay, done. We want to make iliac dissection at the stand edge. So pot balloon is superior to conventional NC balloon with a very short shoulder. From the angle, we can see the stand full expansion. After that, we check the angle. Just test. Enough. We check the flow of the side bench. Good enough. Okay.